You went out and coined this term, the musculoskeletal syndrome of menopause.
Unsolicited, women would say to me, I don't know what's going on, but I feel like I'm suddenly falling apart. It is total body pain called arthralgia, which lo and behold, we've known about for 30 years. Frozen shoulder, which the seminal paper was written by Joe Hannafin in 2011. And then the conclusion of the paper, it says, more work has to be done on the origin of this. It seems to happen in midlife women. What could be the common denominator? Well, we weren't talking about estrogen as the common denominator then. All of these things together I've put into one place under a common nomenclature, the musculoskeletal syndrome of menopause. It packages it in a way that the conversation is easier.
Today, we are excited to welcome Dr. Vonda Wright, a double board-certified orthopedic surgeon who has dedicated her career to understanding the intersection of aging, musculoskeletal health, and menopause. In fact, she's the one who coined the term the musculoskeletal syndrome of menopause, which sheds light on the often overlooked connection between menopause and joint pain. Plus, her background in sports medicine gives her a unique lens on how we can stay strong, mobile, and resilient as we age, especially through menopause. As a team physician for pro athletes and Olympic athletes, a sought-after speaker and the author of several books, she is a trusted voice in the orthopedic field. In today's chat with Dr. Wright, we will talk about her concept of the musculoskeletal syndrome of menopause. Stick around as we talk about menopause and how it affects joint health and muscle health, and how to keep them strong and healthy throughout your midlife. Dr. Wright, I am so excited to do this. It's my first time meeting you in person, and we have chatted so much over the years, so this is truly an honor to have you here.
Well, thank you for having me. Isn't it funny how the internet makes us feel like we've known each other for years, but have met for the first time.
First time in real life.
I'm thrilled.
And also, it's so special because we're both orthopedic surgeons. And as we know, there's only 6% of women in orthopedic surgery. So it's truly an honor. Thank you.
Oh, it's my pleasure.
Okay, so let's get right into it. I have been in practice for about 15 years. And I have always noticed that, women coming in their 40s, 50s, and 60s, they have these different symptoms than the men do. And it's often very gradual and different than what they've experienced before in what's going on in their shoulder, their hip, overall body fatigue. And you went out and coined this term, the musculoskeletal syndrome of menopause. And I probably should have thought of it myself as an orthopedic surgeon, but it just has rung the alarm for so many people out there. And I know you've been doing this work for so long. So tell us about that work and how you got to this term that you coined.
Yeah. So you know what? My career is an interesting intersection between orthopedics and performance and taking care of the athletes. I'm a team doctor, not just a sports doctor. So I'm the one, rain or shine, standing on the field, traveling with them. On the other side, I'm an academic surgeon, and so I've done this body of research that's in musculoskeletal aging and longevity, and really looking at dispelling the myth that aging is an inevitable decline and that there's nothing we can do about it. But in 2012, I added the third bubble to my overlapping Venn diagram, the whole health of a woman. And that is because my first career in medicine was as a cancer nurse. And so at a very, very young age, I came to understand the unique things that women go through, but still did not recognize the why until I went through my own perimenopause. And so the story that I tell is at 40, I had a child, I was in the best shape of my life, training for triathlons, and then I thought I was going to die when my ovaries retired and I no longer had the estrogen, which is an anabolic steroid with receptors on every tissue type in the body. And I'm going to tell you for sure, and we train the same way, there is no training on any of this in orthopedics. None really in medical school. And so as I went through this myself and quickly became an expert by self-education on hormone safety, what is the role of estrogen, progesterone, and testosterone in the body, I started listening better to the women who would come to me. I've been in practice so long, and I'm not the busiest surgeon in the world, but it still means that I've seen about 100,000 people in my career. And so as I listened better, I recognized patterns. Unsolicited, women would say to me, I don't know what's going on, but I feel like I'm suddenly falling apart. And as I listened, I recognized that these were my 46, my 48, my 52-year-old women. And they would say to me, not only do I think I'm falling apart, but I think I might be going crazy, because I asked this other doctor what was going on, and they said nothing was wrong with me, but I know something's wrong with me.
Yes.
Because I feel different, and all of a sudden my shoulder will not move. And then the third thing they said to me, which makes me really sad, but I think it's a huge national issue. They would say to me, and you know what, Doc, I did not want to come in today because I have a really high pain tolerance.
Mm-hmm.
But I couldn't take it anymore, as if high pain tolerance is a badge of honor and something to be shameful for if we recognize. So those things together made me, I'm a curious person, I'm a researcher, started digging deep and like, well, what do we know about someone telling me their whole body hurts? I've never believed fibromyalgia was the blanket diagnosis for every midlife woman with something weird going on. And yet I feel like that is slapped on so many women who have body pain.
Absolutely. And to your point about women coming in and saying, I didn't want to come in because I have a high pain tolerance, I can attest to this as well.
Yeah.
They don't come in just with a frozen shoulder. They come in with a shoulder that literally doesn't move even past 10, 15 degrees.
That's right.
And what you say to them is, how long has this been going on?
Yeah.
And they will tell you months. And you're like, but you didn't think to go see anyone? All of a sudden your shoulder's not working. You can't lift your arm up to put, the dishes in the cupboard or do an overhead press, and you just thought that was okay? I mean, isn't that so surprising?
It's not surprising to me because women suffer.
Yeah.
And they take care of everyone except themselves. So they think, you know what, it'll go away tomorrow. It'll be better tomorrow. I'm busy. I've got 3 kids to deliver somewhere. It'll get better tomorrow. And it never does. And until they're so sleep deprived from not being able to lay on their shoulders. So I get what you're saying. Yes, I'm surprised people are not more proactive, but that is the nature of women.
Yes. Yeah.
Is that
It's sad,
we are
but true,
caretakers for everyone. And so as I dug deep, I identified many things, and I should have added many more to what I described in this paper, but it is total body pain called arthralgia, which lo and behold, we've known about for 30 years. It is frozen shoulder, which the seminal paper was written by Jo Hannafin in 2011 from Hospital for Special Surgery.
Yeah, she's wonderful.
She is. I trained
She's
there.
She's a true pioneer as well.
That's
Correct.
right. And she, with biopsy, outlined the 4 stages. And then the conclusion of the paper, it says, more work has to be done on the origin of this. It seems to happen in midlife women. What could be the common denominator? Well, we weren't talking about estrogen as the common denominator then. So arthralgia, frozen shoulder. We know from the arthritis literature that men have more arthritis before age 50, and women have a rapid progression of arthritis after 50 for no seeming reason. But we've seen that, and we've known that for 75 years. And yet it's never talked about. We know about sarcopenia and loss of muscle. We know about loss of bone. One less known phenomenon is the degradation of muscle-derived stem cells, or satellite cells, which is what my lab studied at University of Pittsburgh. But even things like chronic low back pain because of the role of estrogen in maintaining the disc, the vertebral disc. All of these things together I've put into one place under a common nomenclature, the musculoskeletal syndrome of menopause, fashioned after the gynecourinary syndrome of menopause that was established by the OB-GYN doctors. And here's why, and I know you'll shake your head in acknowledgement of this. If somebody comes into the office in a typical insurance-based visit for 15 minutes, and we can talk about insurance all we want,
yes,
and our
definitely.
relative dread of that, and says, my body hurts, my arm doesn't work, my knee's killing me, I feel weaker. 8 things in 15 minutes is never going to fly. But if someone comes in and says, listen, I'm a midlife woman, I have a lot of things going on. I think I have the musculoskeletal syndrome of menopause. It packages it in a way that the conversation is easier. And given the fact that 94% of our colleagues were born without the advantage of ovaries, they're never going to get it.
They're never going to get it, and they
won't live through it.
Fully understand
it. And they
it.
don't understand it. And so, I mean, that's another big struggle for me, is to get my own orthopedic community to care. But that's why I wrote this paper, not because it is the first work. What I hope that this paper will do is spur more research. And it already has, both my own and other people's research, because it's a big white space. What happens to the musculoskeletal system when there is no estrogen on the alpha and beta receptors? But here's what I did. My group and I say group, at this point I'm not an academic surgeon. I just have a small group of collaborators. We paid the $5,000 that it takes to make this article open access, because the reason good research doesn't get out is because journals put it behind a firewall.
Yes.
They have to pay their own paywall. So it costs $5,000 for an author to make it public access. But I think that's what's needed, because this paper, I didn't check this morning, but last time I checked, has been downloaded more than 328,000 times, which means women have printed it, taken it to their doctors, spread the word, so that it is becoming a common nomenclature. To put that in context, I looked this up because I'm a little competitive and I want to know, but according to the British Medical Journal, JAMA, the Lancet, the big prestigious medical
Everyone's
journals
heard of, yes.
Everyone's heard of, they estimate that their best papers are downloaded 10,000 times, and that 50% of all research.
I love that, Vonda.
Well, okay, I'm going to take the flag. I'm going to take my team did a good job. But what it means is that women are hungry, and they're willing to go to the ends of the earth to find out what the heck is going on. And I think one of the reasons women are going to such adjacent places to find medical care, with or without medical degrees, with or without any kind of real experience, is because
they're not being heard, right?
They're not being heard. Doctors are trapped in an insurance system which prevents us from listening. In medicine, we are taught disease care, not prevention. And so I think this paper gave women a tool to take control back in their own hands in terms of this issue.
Absolutely. I mean, it's such a powerful tool for them to have.
Yeah.
And as you stated, so many practitioners, and I think it is a lot of the men, especially in our field, they don't really understand. They don't have a box they can put it into.
Yeah, and how could they? They don't have ovaries.
Yeah.
And the only thing they know about this is that suddenly their wife is not the same person they married.
Yes, exactly.
Well, and by the way, gentlemen, you're not the same person we married.
We married either.
Yeah, but you know what? We can get through this if we have a greater understanding of what's going on.
Yeah, absolutely. So let's go back to the exam room. So you're listening to these stories and you're starting to put these pieces together, which you already knew from your own life even. What do we do to help these women? Because in medicine, everything's so siloed, right? You go see your orthopedic surgeon and then you go see your primary care doctor. Those two doctors are not necessarily talking to each other. And so how do we come up with a comprehensive plan? And what work are you doing in your own exam room to make sure? Because as orthopedic surgeons, we are not prescribing HRT yet.
I am.
You are?
Yeah.
That's amazing.
Why is it amazing?
Because that's not our training.
You prescribe ANSEF. You're not an immunologist.
Absolutely. I agree with you 100%, but it's been years since I've prescribed anything outside of ANSEF, Vanco, corticosteroids, a Medrol dose pack.
Here's how I'm going to frame it for you.
Yes.
For orthopedic surgeons in specific, we are one of the most competitive fields in all of medicine. We have the best test scores. We are some of the most curious and creative and hardworking. Not to say other doctors are not, but there's a reason why our field is one of the most competitive. So I believe that we are capable of learning. So for instance, within orthopedics itself, I did not learn in my residency or my fellowship how to do hip arthroscopy. And yet I was one of the first hip arthroscopists in the whole country because I had to learn a new skill.
No, that's a great point for our listeners, actually, because sometimes people don't recognize that where you do your residency will influence the procedures that you do because you just got more training. For instance, I went to Columbia, so I did more shoulder. But those other procedures and what your practice makeup looks like, you're going to have to go do that additional learning yourself,
well,
right?
in my case, you brought me to your conference because I've been in practice so friggin' long.
Yes.
So I did not learn it because it wasn't taught in my fellowship. It didn't exist. We created the field of hip arthroscopy, right? So all I'm saying, really, the point I'm making is if lay people with a bachelor's degree in nothing can learn enough to become experts in something, I think smart, savvy doctors can step outside their box. And if they want to, they don't have to prescribe hormones, but learn a new skill, right?
Yes.
So, before, for instance, we're surrounded in my life by a lot of OB-GYN doctors. However long ago fertility happened, they weren't trained in that until they
True.
created a new field.
Yes.
And created now it's very common, right? But it's just the same thing. I step forward to challenge orthopedic women in particular, which also have not picked up this mantle yet.
Please do. Challenge me. I love it.
To step in front of this and become the experts. We own the musculoskeletal system.
Yes.
But if we do not pick it up, it will be given to the naturopaths and to the chiropractors and people who are willing to learn new skills. So even when I try to put this in front of orthopedic women, we are still so siloed. We can't possibly think outside the box to consider the whole person. So when you asked me about my clinic, a woman comes in and I review my thing and, she's 46 and her shoulder hurts. She's probably got a frozen shoulder, right? I go in and I don't even start with the frozen shoulder. I said, I say something like, how's your shoulder? Does it move? And she's like, it doesn't move. I turn away from that. I start talking about, I wonder if you're sleeping. And we go down the road of helping her explore what perimenopause means, to put the frozen shoulder in a context of your body is so inflamed right now because there is no estrogen sitting in the estrogen receptor. This is not just your shoulder. This is your brain with brain fog. This is your night sweats. And as I start to describe to them what they may also be feeling, they start crying. Not because
you put it into context and so many other things are going on.
Because I am listening to them, because nobody is listening. And I've started saying this a lot. As doctors, we are not just the masters of anatomy. We are the architects of trust. You cannot build trust if you are not listening to people. If your hand is on the door, you have to give somebody a time to express themselves. So as I start to help them recognize what's going on with themselves, they're going to trust me when I say this is going to take 2 years to defrost if we don't do A, B, C, and D. Part of your treatment plan for your frozen shoulder is making your hormone replacement decision.
Yes.
They're surprised when I say that because if I can shoot up a shoulder all day with steroids, which I don't love to do. I can go to the next step in line, which is platelet-rich plasma, which without getting control of the inflammation of the body by making a hormone replacement decision, she will be back with another frozen shoulder and dyslipidemia and total body pain. So if we're trying to be a preventive doctor and treat the whole person, it takes a little bit of being uncomfortable and being, as you'll see in my talk tomorrow, what I describe as being a weird Barbie in my own field. Because if I was going to be a standard Barbie in orthopedic surgery, I would stick to the pro and college athletes running out onto the football field, treating each joint as its own, not in concert with the rest of the body. But I'm a weird Barbie, and I always have been. And this is how I think women deserve to be listened to.
Absolutely. Okay, so you're doing the hormone replacement therapy. You're helping them get the actual treatment that they need. How are you tying that into the orthopedic treatment? You mentioned cortisone, which I also agree with you. It's not always my first line of treatment. I think cortisone has a great place, but I think platelet-rich plasma, although most people do know what it is, I don't think people fully understand the power of how your own body can heal itself. So take me through after you've talked to them about the holistic,
shoulder.
Exactly, how you're treating the shoulder and how you're getting them the care that they need.
So after we recognize that there's a lot going on, and that today you came in because your shoulder doesn't move. The way I teach people, and I handwrite notes for everyone because it increases communication, we talk about making your hormone replacement decision, and I give them resources. Like if you're a data person, you must read Estrogen Matters. If you need to know what's going to go on in menopause and perimenopause, then you need to read the New Menopause to start with. I mean, there are lots of menopause books at this point, but here's one you can start with. If you want to know what to do next, then pick up Unbreakable, my new book, because I think women need to be literate about what's going on.
Definitely.
And if then they need hormone replacement therapy, and I'm not the right person to do it because they have a lot of, because to do hormones, every woman needs a risk assessment, right?
Yes.
And so I triage them out to, okay, this is, you are very healthy. There's not a lot of other things going on. I can do this for you. Versus you have a lot of XYZ. I'm going to refer you, and I have in my pocket. This is how we take care of pro athletes, people. It's not just one orthopod on the field. The orthopod in charge builds a large group of consultancy players. Like every orthopedic surgeon leading a pro sports team has a gynecologist, has a dermatologist, has an eye doctor, has every subspecialty on speed dial, has a nutritionist. So that is the same way I treat every single one of my patients. I have all those people on speed dial. So when I need to refer out for hormones, because people fly in to see me, I don't always have a license in the state they are.
Sure, yes.
I know the person to send them to. So that's number one. Number two, mobility matters. We're not only going to get you in physical therapy, but the rest of your body should be working out in this way. What are we going to do about our nutrition? Inflammatory foods contribute to the inflammation you're already feeling because your estrogen has gone away. So here are the tenets of anti-inflammatory nutrition. And so finally we get to the medical intervention. If they're in screaming pain for a frozen shoulder, I'll give them a steroid injection, knowing that I'm going to send them to therapy where the therapist is going to lean on this arm and get it to move. Because if we don't get it moving early, what Joe Hannafin's paper showed is that the inside skin of the joint, the capsule, becomes so infiltrated with inflammation and fibroblasts, it physically shrinks.
Yeah.
That's why it takes 2 years to defrost, for it to remodel.
And that's a surprising thing for patients to hear.
Yeah.
They can't believe when you say 1 to 2 years. They are just shocked by that.
And this is only one of the musculoskeletal things. I mean, if I'm going to choose one to save this country, I'm going to choose bone health.
Yeah.
Right? Because, I started talking about, I've talked about it my whole life, but really in a big public way last July when I introduced Stephen Bartlett on Diary of a CEO to the wonders of bone, right? And that it's not just a structural entity, but it's a metabolic organ. Well, I love the fact that lots and lots of people are talking about bones, because here's the deal. If I choose one thing of the musculoskeletal syndrome of menopause to save women about, it's going to be save their bones, because 1 in 2 women will have an osteoporotic fracture in their lifetime. So
Yes.
if it's you and me, it's going to be either you, Pamela, or it's going to be me. That makes it really
It'll be someone
real.
else, because I see you lifting your weights, and I'm doing it too.
I know. It's probably not
Yes.
but you know what I mean?
Yes.
It's so prevalent, right? And yet people don't realize. And I get DEXA scans on everybody, and I have 20-year-olds, 24-year-olds that come in with osteopenia and osteoporosis, because bone health is a lifelong adventure. It's not an old lady problem.
No, it starts
early. At 15.
And that's the problem, is the older women, 60s, 70s, 80s, they come in and they say, what can I do for my bone health? Do I take vitamin D? What do I start doing?
Yeah.
And it's hard to have that conversation with them, because I'm like, you need to talk to your granddaughters and your daughters and get them on it now.
That's right. That's right. So we can treat poor bone health at every age, but I totally agree with you. 65 and 70 is way far into the future. I mean, there's so little we can do then, versus I'm going to talk to my 17-year-old about it yesterday. I'm like, you have got to go lift more weights, because we reach peak bone density at 30.
Yes.
It's critical between 20 and 30. In fact, last week I had a woman, 20. She was a dancer. I did a bone density, and she's osteoporotic actually. And I said, listen, okay, we have 10 years to get this right in you. this is how we're going to do it. Because anybody before 40 that has the full complement of estrogen, we can get in front of this, because estrogen is building bone. It's controlling the osteoclasts. We're still building enough muscle. We have a runway. But if we wait until insurance pays for a DEXA scan, which is 65, which is a travesty, in Australia it's 70. I think it's an economic problem. You're just behind the 8 ball, because, unfortunately at my advanced age, I still have to take trauma call.
Yeah.
And when a woman breaks her hip, of which 70% of hip fractures are women.
It's devastating.
It's devastating.
Yeah.
They do not return to their homes.
It will alter your life. Exactly.
Oh, it'll kill you.
So let's switch gears here to that exactly. So what did you notice in your own training and that you've been imparting upon the younger generation in terms of cardio versus weightlifting? I know you often say throw away those small weights. So tell us a little bit about that and how you're reaching the masses in trying to get this out there, that we've got to start when we've got that estrogen-rich environment.
So in my own training, when at University of Pittsburgh, it was a level 1 trauma center, and someone would come in with a hip fracture, and the orthopod would put a nail in it. It's the trauma service. It's going to take care of them. And they had set up, they were ahead of their time, a hip service protocol such that they got a DEXA scan, connected to endocrinology, connected to their internal medicine doctor to try to ebb the flow of this fracture pattern that's going to happen, because fracture is the number one predictor of future fracture. That is not the rule across the country. Often people break, they get a cast, they get a rod, and then they disappear into the wilderness, not realizing that nothing is done
afterwards.
Why did I fall? Was it just trauma? Well, unless you're wrapping your car around a tree in high energy situations, why is our ankle fracturing when we trip off a curb?
Yeah, does not make sense.
That doesn't make sense. It's not high energy. It's because your bones are not strong enough. So I think across the lifespan, all doctors need to be, they don't have to be experts in it, but you can't treat what you can't see. We say that in orthopedics all the time. If you don't know what exists, you can't really identify it. So at least have it in the back of their mind to look at a woman and say, or ask the questions, is your mother shrinking? Are you shrinking? Are you getting shorter? Do you vape? Did you ever smoke? I mean, part of the social history, these are all risk factors. Did you have asthma and have to take high-dose steroids? Do you have an autoimmune disease? So many women have autoimmune. These are all risk factors that you don't have to be an expert in all these, but you have to recognize that there are risk factors so that you can plug the woman in. And so what I've done for a very long time, but it's, to your point, it's exploded in the last couple of years, is I have always been a public educator, meaning I wrote my first book in 2000. It was released in 2008. It was all over TV and radio at the time, because now we do podcasts, but it was radio at the time. And in magazines, trying to get people concerned about their musculoskeletal health. Well, now, because people are listening, all these things are catching on, and women are becoming more self-educated. And I think it's a shift in generations, because millennial women are self-educators. They will deep dive first and then come to the doctor with information and say, what do you think about that? Baby boomers, not so much. Baby boomers are still of a generation where the doctors are kings and queens. And this is a gross generalization, but generationally speaking, that's what I see. So the more you educate the public, the better they're going to be at their own health care, the less likely they're going to go off the deep end and do something that's only been tested in rats.
Yes.
That they hear by. So I think doctors, experts like you and me, have an obligation to get out of our ivory towers and communicate with the public. And if we don't do that, we can't be upset that the public goes wherever they can find the best information and people that will listen to them.
Yeah, and I think we especially have an important part of the conversation because we're women. And I know, I mean, as a Gen Xer, older millennial, that's what they call it, cardio, eat less food, which is the wrong thing to do.
Right. So women have been taught that we need to be this big.
Yeah,
like
fit
my
into
little
small
pinkle.
spaces. Be small.
Be small.
Yes.
Don't say much. Put your leotard on. And so even my first books were all very, very functionally based, like free weights and body weight and mobility, and it was good. However, my teaching has shifted now towards, because I take care of the public who has lost their estrogen or are losing their estrogen, that we must take advantage of the lifting heavy to stimulate muscle protein synthesis. Estrogen is an anabolic steroid, meaning a building steroid. If we don't have that, we have to teach our body that we're still living, and mamby-pamby pink weights will not do that. You have to ask yourself what you're lifting for. Maybe when we're younger, we're lifting for endurance and hypertrophy, so we lift lighter weights, more reps, and that's fine. There's nothing wrong with that. But in midlife and beyond, we are lifting for power, meaning strength is what the total volume we can lift, our body weight, for instance. Power is strength over time. Can I avoid falling down? Can I retrain agility, which is part of what I prescribe all the time, foot speed, so that you don't trip over your bag, the curb, your dog, and fall down and break? Because you know, as an orthopod, a few people break and then fall down, but most people fall and then break. And so if we can avoid that, so my prescription for exercise still follows the same format, which has always been FACE, face your future, flexibility and mobility of the joints, aerobic exercise, which we can talk about, carrying a load, which is another way to say weightlifting. It doesn't have to be iron. It can be a log in the woods, like Kristen Holmes from Whoop, all the time, lifting up logs and rocks in the woods. It's effective. Or I have a 30-pound grandson. That's effective, right? And then E is equilibrium, balance, and foot speed. Because if we cannot stand on one leg, or we reach over for something and we tip over and fall, we're going to break. We don't always break, even with low bone density, until we fall.
Yes.
So that's how my exercise prescription has evolved over the years as the population I care for has evolved and science has changed.
Okay, so you mentioned earlier in this chat about educating our own field.
Yeah.
Mm-hmm. I feel so passionate about that as well, Vonda, because I stopped going, actually. I used to always go to the AAOS conference every year.
You know what? Honestly, I have too.
Yeah, but why don't you share why? I bet our reasons are the same.
You know what? And I always have to preface when I say something like this with, you know what? I love the guys we trained with.
I do. I have such fond memories.
They're amazing
I have great
people.
mentors, and they're all male.
They're brilliant. They're hardworking. They have this work ethic. But when I go to those meetings, it is the same group of guys in gray suits saying the same thing every year. And when I, being the weird Barbie in the group, initially studying musculoskeletal longevity, in a time when I started training, I asked one of my mentors, what's the oldest you would ever put an ACL in an athlete? And he's like, I don't know. How old am I? Maybe I'd put it in. That's not an answer. Let's do that answer based on the capacity, the physiologic capacity of the athlete. Because we have athletes in their 40s, 50s, and 60s doing amazing things.
Absolutely.
Give them a freaking ACL so they can function, right? So I no longer, and I used to be on all these committees, and I just found that there wasn't the curiosity to step outside the notch. Mm-hmm. For those of you who are in orthopods, the notch is the 1.5 inch space in the middle of the knee where we're still trying to figure out where to put the ACL graft. You know, and thank God we have brought it from vertical down the wall, whether it's single or double. But I'm just saying that is work worth doing, but there is so much more work worth doing that never gets airtime because we're stuck in a box of cronies that are supporting each other's work. And there's nothing wrong with that, but it leaves so many other important pieces of information out in left field. Now, what I am encouraged by is that although my generation of surgeons got very little airtime to present our work, the generation of surgeons, which are 10, maybe 15 years younger than me, are on the podium. They are on the committees. And so I think we're changing. But the fact that we still have only 6% women in all of orthopedics, to reach a critical mass of about 33%, it's going to take decades. It's going to take 100 years, because when I trained, there were 3% women.
Yeah.
Women training now, there are 6% women. Mm-hmm. I mean, how long is it going to take?
Yeah, it's going to take a while, but I think we have to show up to those spaces, AAOS and all the spaces that are mostly men and, like you said, the older ones.
Yeah.
I also think we create new spaces, which I know you've done. And what I'm so honored and thrilled about is that you are part of the Pinnacle community as well, because I have found a lot of inspiration and light and joy and just confidence within this group of women that I didn't have with orthopedic surgeons. I tell my co-founders this all the time, that you all have changed my life. And so I'm so thrilled that you're also part of this community, because this is how we further this care for our patients and also motivate and inspire this new generation. So Vonda, I just want to thank you so much for being here today and the work that you're doing. I would love for you to tell our listeners where they can find you. I know there's a number of places.
Yeah.
And tell us about Unbreakable as well.
So, well, I'm thankful that you have me here. And there is nothing so amazing than to be in the presence of a group of women that you don't have to explain yourself to, right?
Absolutely.
Because being a surgeon, being a doctor can be very lonely for women, because it's hard to explain to your friends who are accountants or who have given up their careers to stay at home what our days are like. So to be in a place where you actually don't even have to explain that is just so
really
heartwarming. It's really nice,
Yeah.
right? So my work is all over the place. I have a website, Dr. Vonda Wright. I am every day on Instagram. It's at Dr. Vonda Wright. And my latest book, you have another book of mine on the Pinnacle. You have my book that's about youth sports injury.
Young athletes, exactly. That you did with Dr. Mark Miller.
Right, a pillar in the orthopedic community.
Yes, absolutely.
Yeah.
You can get CME for that book.
That's right. And so this new book, Unbreakable, picks up where all the menopause books leave off, right? There have been, Mary Claire's was one of those seminal books in the menopause space, and then there have been a lot coming after. Most of them have one chapter on lifestyle. My book, Unbreakable, is framed around women's longevity, because the longevity space is largely populated by the bros.
Yes.
And that's fine. That's the way it started out, but women deserve their own attention, because our aging is cataclysmically different than men's. And so Unbreakable takes you from understanding menopause and midlife into how to build an unbreakable future, so that we do not become one in the 3 women who ends up frail in a nursing home, unable to live in the house she raised her children.
Thank you for the work that you're doing.
Thank you.
I'm so happy that the listeners are going to be able to find you and hopefully read your book and carry through this work, because we all need to share in that responsibility.
It's my pleasure.
Thank you for tuning in to The Resilience Factor. If you're ready to build a stronger, longer-lasting body, make sure to subscribe and share this episode with someone who's ready to thrive. You can follow me at Dr. Mehta for more expert tips on strength, recovery, and orthopedic health. Until next time, stay strong, stay smart, and stay resilient.